Dr. David Odat. He will speak on complication in oculofacial cosmetic surgery.
Yes, exactly.
Please.
Oh, thank you. Good afternoon, everybody. My name is Dr. Thabit Odat. I am from Jordan. I am oculoplastic surgeon, and I am the president of the Jordan Ophthalmic Society. So my talk today will be about the complications in oculofacial aesthetic surgery. And as you know, these complications are usually nightmares for the surgeons and for the patients alike. I have no conflicts of interest to disclose. So aesthetic surgery, as you know, continues to become increasingly popular globally. This increase in popularity will inevitably results in the number of potential complications associated with these procedures. In this presentation, I will describe few complications encountered with frequently performed cosmetic oculofacial procedures and their associated managements. Of course, not all of them. So to start with, I have this patient who is a 30-year-old female patient. She worked on social media. She came for bilateral tooth repair that improved significantly with low concentration of phenylephrine. We did for her bilateral conjunctival monoclectomy, 8 millimeter, and she was very happy and satisfied. But later on, a few months later, she asked for upper blepharoplasty and brow lifting. So we did the procedure as she asked for, but the nightmare was after 1 week, she came with necrosis at the incision sites, as you see in this area. I don't know if it's work or not. So you can see the necrosis in the forehead around the incisions. So unfortunately, the patient, she came after 1 week. She didn't report any pain or anything during that period because she thought that this is normal. So she came after 1 week. We couldn't help her a lot. Another case, she's a 52-year-old female patient. She had bilateral upper blepharoplasty with monoclectomy and bilateral pretracheal brow lifting. 1 week post-op, she presented with left temporal suprabrow swelling. Of course, this was hematoma. In this case, you should immediately evacuate this, otherwise the patients will have a site for infection and, as you know, fibrosis. So, brow lifting, there are various brow lifting techniques that ranges from direct brow lifting to higher sophisticated procedures like endoscopic brow lifting. The patient's hairline and aging changes of the forehead and brow are typically the two guidelines or guiding factors that lead to selection of the techniques. So brow lifting technique, brow lifting common complications, as you know, it could be simple as revision, it could be hematoma, it could be anesthesia to sensory nerve injury, etc. So we'll discuss few of them, not all of them. Each brow lifting technique has its own incidence of complication, and in a systemic review of complications in brow lifting technique, need for revisional surgery has been found to be highest in hairline, which was 7.4, in comparison with direct, which was 2.4%. The other complications that we might encounter is the alopecia. The rate of alopecia was highest in the coronal, which was 2.2, and temporal in 1.5% brow lifts. The most common complications encountered in endoscopic brow lifts were alopecia 2.8 and dumbness 2%. So anesthesia also is a common complications, which is usually temporary, but as long as you are in the correct plane and you do not touch the supraorbital or supratrochlear nerve, numbness will not happen. Hematoma. Of these, hematoma remains the most common complications and can lead to prolonged facial edema and eventually flap necrosis. That's why you should manage hematoma immediately. How to manage? You should actually do liquefaction with normal saline, and sometimes you have to add antibiotics through the incision, then do massage to liquefy the hematoma, and then do massage upward toward the incision. And this way you can get rid of the blood, and later on you can aspirate the remaining liquefied blood. Facial or scalp flap necrosis itself constitutes a vexing and grievous complications for both the patients and the surgeon. The incidence rate is 0 to 3% after face lifting, but there was no reports after pretracheal brow lifting. Of course, there are many cases with brow lifting technique that has necrosis, but unfortunately, I couldn't find any in the literature review.
It's
What
not working time. I am looking in my.
So shall I continue? Or?
Yes.
Yeah.
Yes.
So what could be the cause of the necrosis? Actually, the most common cause is the cautery, or it could be tight wound, or the sutures if they are tight, or if you use any implant. As you know, the forehead area or the temple area is highly vascularized, but it's like a watershed area. If you put too much pressure, the blood supply will be less, and then there will be necrosis. And the most usually the dermatologists who use filler in this area, usually they have these complications. How to manage the existing literature regarding the management of flap necrosis includes immediately you should remove the sutures. Then you should give platelet-rich plasma immediately, and you should increase the blood supply to the wound by giving nitroglycerin cream, or then you have to treat the infection if there's any infections or if there is any ulceration. And of course, you should cover with antibiotic. Flap necrosis, this patient, as you see, she called me after 4 days that she is having like rashes on the forehead, and then she started to have dusky color in the temporal area. And then she started to take photos, and every day she sent me photos telling me that this is getting worse. So what we did, immediately removed the sutures after 4 days. We gave her PRP and started to treat this area. And fortunately, we managed to control the necrosis. And this is how she looks after 5 weeks. Flap infection and necrosis after 1 month of surgery, as you see, can happen. It doesn't mean that if the patient is having the surgery after 1 month that she will not have these complications. For example, this patient, she have this infection and this necrosis after 1 month of the surgery. In severe cases, as you see, it can have chronic ulceration. In this case, you should consult the people or the doctors who are more specialized in chronic ulcer treatment. And you can use, sometimes you can use antimicrobial advanced extracellular matrix like Endoform, which helps a lot in this case, in these patients. Sometimes the patients might have brow asymmetry. And the brow denseness of asymmetry was highest in the temporal left, which was 1.5%, and direct left in just 0.9%. Sometimes the patients might have paresis or paralysis due to temporal branch injury. And as long as you're in the correct plane during the dissection or during the surgery, then the patients will not have this procedure. Usually, this case, the brow paralysis, usually it is transient. It usually lasts from 2 weeks up to 1 year, but most of them, they will improve. Actually, the patients, usually, they are happy with the paralyzed brow. They will not be happy with the normal one, because the normal one, there is wrinkles, the patient is, the brow is higher, so usually we give the Botox in the normal side, not the affected side. Scarring is also a big problem for the patients, and you know how to treat it. The safety profile of the various brow lifting technique are favorable. So blepharoplasty complications, it could be upper eyelid overcorrection or lag of thalamus, could be lid retraction, asymmetry, ptosis, etc. So superficial ecchymosis and hematoma usually is the most common one, and usually this is transient, it doesn't affect anything, as you see in these cases. And orbital hemorrhage with visual loss is the most grievous complications. In this case, you should treat immediately, manage the patients immediately. How to manage? You should open the wound immediately and evacuate the hematoma. Sometimes, if you are not the treating surgeon, sometimes you have to do lateral canthectomy and canthoracis. This Lieutenant General, he has upper blepharoplasty. Yeah. He has upper and lower blepharoplasty, but after 3 hours, he called me that he's having severe bleeding. Okay, so we opened the wound and we found that he is having bleeding due to high blood pressure. You can see the bleeder here. So it was a quick management for him. Just we do exploration and do cauterization for this bleeding blood vessels, though he has a lot of blood loss. Sorry. Retrobulbar hematoma, the risk is approximately very, very low. It's 0.0052% of cases based on a Serbia study. Treatment should be immediate orbital decompression. Scar anomaly also can happen.
Only two.
Pigmentary abnormalities also. Yeah. And wound dehiscence also is a common complication, especially if you give the patient for the residents to remove the sutures. This might happen. Upper eyelid overcollection and leg thrombosis also could happen. Dry eye is very, very common. So recommended to delay blepharoplasty after 6 months after LASIK surgery. If the patient is having refractive surgery, don't do the surgery immediately. Wait for 6 months at least. Canthal webbing also can happen. Medial excision beyond the medial canthus, medially or extending inferiorly near the lid margin can cause this. Laterally, you should leave at least 5 millimeters between the upper and lower incisions. And this is a very interesting case. She has severe blistering after 1 week of the surgery, and this was due to contact dermatitis. We thought that could be herpes or something else, but luckily it was just contact dermatitis due to Steri-Strips tape. In conclusion, despite the many possible complications of aesthetic surgery, a comprehensive history and physical exam followed by precise operative planning and execution can lead to reproducible results. Thank you very much.
Thank you very much for your excellent presentation.
Thank you.
Now, Dr. Raid he will talk on single botulinum toxin injection in the treatment of strabismus. Very good. Good topics.
Okay. Good evening, everybody, and I would like to thank the APAO for giving us the chance and the opportunity to present here in New Delhi. My talk will be about single botulinum toxin injection for the management of strabismus. So, in introduction, botulinum toxin is a neurotoxin protein produced by Clostridium botulinum that causes presynaptic inhibition of the release of acetylcholine at the neuromuscular junction, creating short chemical denervation. A treatment of strabismus by botulinum toxin requires multiple injections under local or general anesthesia, depending on different factors, age of the patient, for example, and the setting in your operating room. So in our study, we conducted a retrospective analysis at a tertiary hospital in Amman, Jordan, to identify 29 patients who received single botulinum toxin injection as a treatment of strabismus between October 2018 and October 2019. We defined success that indicate full control of the angle of deviation or residual angle of deviation less than 10 prism diopters. Partial success indicates partial control of the angle of deviation more than 10 prism diopter and less than the original angle of deviation. And failure indicates no change or even overcorrection more than 10 prism diopter. So the results, the demographic characteristics and the clinical features in our sample in table 1 that we're going to show you in the next slide. It shows total number of patients in the study was 29. Most of them were females, had esotropia, and aged less than 6 years at the time of treatment, and mean age was 7 years. Around 19 patients received botulinum toxin bilateral injection. For bilateral injection, the dose was 2.5 international units per muscle. For unilateral injection, we used 5 international units per muscle. Patients were seen at 1 week, 1 month, 4 months, and 6 months. So this is the table that summarizes the demographic data of our patient sample. This graph shows the angle of deviation after the injection. In this figure, as it shows, the mean angle of deviation of the whole group of patients decreased significantly during the first assessment visit, the first week post-injection, from 38.97 prism diopter to 19.48 prism diopter, and this indicated 20 prism diopter improvement in the first week after injection. Can we use a mouse here? And here, so this is the dramatic reduction in the angle of deviation. Then it started to come again, the angle of deviation. The highest percentage of improvement in angle of deviation 6 months post-injection was found among female patients, patients who aged less than 6 years, patients with esotropia, and patients who underwent injection in one muscle. The lowest percentage of improvement in the angle of deviation, so we can consider this as poor prognostic factors for improvement after single injection, male patient, patients who aged 18 years or more, patients with exotropia, and patients who underwent bilateral injection. So unilateral injection has better prognosis than compared to bilateral injection. Treatment effectiveness in this figure 2 shows 5 of 29 patients. We have the total number 29 patients. 5 of them, they had a successful treatment in the 6 months post-injection. These 5 patients represent 17% improvement, while around 7 out of 29 patients had partial improvement and 17 patients had no improvement at all after single injection. So we have 17% with full control, 24% with partial improvement, and 59 with no improvement. The adverse effects in our study, it showed excellent safety profile. Only 2 patients developed overcorrection, around 7%. One was a transient exotropia that resolved completely by the end of the follow-up period, and the other one developed large overcorrection that partially resolved by the end of the follow-up period, which necessitated surgical correction afterwards. None of our patients developed ptosis after the injection. So the economic profile, and this cost is in regard to Jordan economics. Our analysis showed that the total average cost of a treatment, including medical and non-medical costs, was $410 US. The cost of surgery in Jordan was around $1,200 US. So in discussion, our results showed that there was a statistically significant difference in the average of angle of deviation values before injection and in the 6 months post-injection. Moreover, our results showed less success rates compared to other studies, such as a systematic review and meta-analysis study that included 9 studies, which showed that the mean reduction of angle of deviation was 30 prism diopter compared to our study, which is only 20 prism diopter reduction angle of deviation. The difference in success rates may be because most of the studies included the analysis discussed repeated botulinum toxin injection. Our study used only single botulinum toxin injection. Although results in our study were statistically significant, we think it was clinically unsatisfactory. So patients who have partial improvement, they need surgery at the end of the day, or another injection. So it was clinically unsatisfactory because patients with partial improvement and patients in the failure group both needed repeated injection, which means a clinical failure rather than statistically failure. The accumulated cost of repeated injections, as well as absence from work and other social factors, may outweigh the cost of surgery. So botulinum toxin injection for the extraocular muscles is a recognized and established modality of treating strabismus. Our study concluded that the use of single botulinum toxin injection for treating strabismus achieved satisfactory results and was cost effective compared to other treatment modalities. There is a definite need for repeated injection to achieve good results. It might be used as a temporary treatment while waiting for definitive surgery. Thank you.
I just want to ask you, the
Yes.
injection was given under guidance of some sort of, or just blind?
No, actually it was given under general anesthesia. We will grab the muscle as in the bridal suture that we used to do it in the extracapsular cataract surgery before. So we used to grab by the forceps and inject in the belly of the muscle.
Any question?
No, maybe the dose is because in unilateral the dose was 5 international units. For bilateral the dose was 2.5 international on both sides. Maybe 5 international units is more appropriate as a dose for the muscle. But the recommended dose in the literature is 2.5 international units bilaterally or 5 unilateral. That's the recommended dose. Okay, so we used Botox, the brand Botox by Allergan. We constitute the medicine 2 ml of normal saline, and we inject it inside the vial. So total is 2.5 on the insulin syringe. Yeah, 0.1 will contain 5. Yeah.
Are you still using it or
No.
no?
Actually, our conclusion is you can use
He's
it
not present.
as a temporary treatment
He's also not
while waiting
present.
for surgery.
But
If
he's
you have long
present
list, you
and
can just make the list shorter by giving this
he's a
injection.
speaker, but
Or after
His one
doing
is not
strabismus surgery, if you have like residual angle of deviation, you can give the Botox. But as a primary treatment, we think in Jordan, doing surgery is cheaper than repeated injections. While in other
Last,
countries, maybe
session
surgery is
also
much higher price
somebody missed.
compared to repeated injection.
Okay.
Yes, we did that for adults.
And same
Local.
dose, same dose, same dose.
Same dose, local anesthesia. Topical, no, topical, yes, topical. Topical eye drops.
They are not available.
Sorry?
They are not available. Okay. Take it.
No, we give it for only like exotropia patients, but we didn't use it for thyroid, no. Because we have patients who were 30, 1 or 2 patients.
Okay. Thank you very much for
Thank
your
you.
excellent presentation.
Thank you.
And I think we can conclude now, as Ashraf is still not coming. It's not. Nobody will wait for him for a long time. So, if you want to say something, you can.
Yeah. So I would thank the APAO for.
On that one. You
Yeah.
take that one.
I would like the APAO for this opportunity, and I hope also this is not going to be the first time. So I will be more than happy to repeat such a meeting with the Ophthalmic Society of Bangladesh for the other meeting.
Okay.
With the APO.
Yeah, with APO. Yeah.
Of course, Jordan should come in APO as a member organization.
Yes.
Right. So I'm also very happy, though it is so poor, no audience, no speaker, but 2 speakers at least present their cases so nicely. That is enough. More than 5.
Yeah, the start may be like this, but we promise that in the future we're gonna have like
Big.
collaboration
Just-
with APO, with the Asia Pacific countries.
Yes.
I think West Asia should collaborate with the Southeast Asia also.
Okay. So there is a memento, but still there is a mistake. Only one memento correctly has come, and the memento which are coming, they are not available. They are not coming. Not Ashraf. Ashraf is here. If only these 3 your senior has given. Okay. So, Shatnai, you, please come and take this award. That is the appreciation award.
Thank you very much. It's my
Okay.
pleasure.
This is light.
Thank you. Thank you. Oh, pleasure.
really sorry that I could not give you any memento. Excellent presentation, really.